All right. California law subscribes to two different types of criminal sentencing: determinate sentencing and indeterminate sentencing. Determinate sentencing is a sentence for a specific number of years. Indeterminate is something like 25 years to life. It's X years to life. Yeah. Once an inmate serves his or her determinate sentence, he's placed on parole or probation. Once an inmate has served the numeric part of their indeterminate sentence, they're placed on parole or probation unless an inmate has a mental disorder or illness. If the mental disorder or illness presents public safety, a risk, then there are exceptions to that parole or probation law. It's referred to as the mentally disordered offender law, or MDOs. And it's really to protect society from certain prisoners as dangerous and to treat those mental disorders and to give the people. MDO law pertains to the CDCR, California Department of Corrections Rehabilitation, and the Department of Mental Health, DMH. And the clinicians who do the MDO and SVP evaluations, there's a close-knit group of them, I'm told. They're all certified by the state, and they do contracts every year to renew to see if they are going to get referrals for that. And I hear it's highly political and it changes all the time. And it's very hard to get into. So the history behind it had to do with a stalker who kept on stalking his intended victim and then came back and recidivated. And so I was saying the CDCR and DMH provide treatment. Those are the two contracted places to provide treatment for MDOs and SVPs under this California law. It's not like they can be released to their private psychiatrist on the street if they are found to be mentally disordered offender. There's 6 different criteria, and they have to meet all 6 of them, and if they don't, then they don't get the hearing. But if they do, then they get to be evaluated, and they have the 2 evaluators, and they have to agree. And then if they both agree, then they get assessed again at the Department of Mental Health, and there's the hearing that goes on there to see if they should stay or not. So if you did have an Access 2, like borderline or antisocial, you'd also have a comorbid Access 1 that would be a qualifying offense. They have to have had treatment. You do miss a lot of them, especially the pedophiles, because they don't necessarily get treatment in the prison. I did not know about the loophole, though, that if they go out on parole, they're mandated for sex offender treatment, and they come back, then they could be found to be MDO'd if they had a comorbid mental health disorder. That's kind of interesting with the loophole. And then the statute has specific wording for severe mental disorder, what that means, remission, what that means, and how people can get out. It's very, very interesting. I actually tested a gentleman, very interesting case, who said that he had been malingering. He'd been malingering the whole time he was in prison last time, and the whole time he was in jail. And he said the food is better in the hospital. He was at Santa Rita. The food is better in the hospital. So he would purposely not take care of himself, not shower, not whatever, and be sent to Santa Rita, or be sent to the hospital while he was awaiting being sent to prison for like a year. He was in and out of Santa Rita like 8 times. And so he was telling his treatment provider at San Quentin, I don't want to be part of mental health. I'm fine. Just take me out of this program, because last time I was in San Quentin, I faked so good that instead of paroling me, they MDO'd me and sent me to Atascadero. Well, I got my hands on the Atascadero records that actually said, the discharge summary said that they had released him because it was unclear if he had a mental disorder or if he was actually faking like he said he had been. And I'm like, that's awesome. It was the most bizarre thing. Of course, all of my tests showed that he wasn't malingering. He was a little needy, but I mean, personality tests really didn't show he had a personality disorder. And but he had a violent crime. He had injured some people. So, but it wasn't psychotic per se. He had a history, of course, of drug use and poor work history, and dropped out of school in 11th grade. All the stuff that He was young, and he lived with his mom. He'd always lived with his mom, and his mom said that she never saw him as acting crazy except for when he was on drugs. So I started my report, and I said, it seems like what he said was true. He's able, absolutely full affect, did not have any signs or symptoms of a thought disorder, wanted out of the mental health program, said that he was refusing his medication, was not taking medication. He was prescribed medication, not taking medication. And I'm like, check his levels, see if he's actually taking the medication or not, and if not, then go ahead and release him. And he seems to be able to fool people quite nicely. I tell him, you're going to be tested for medication. If the medication is in your system, then your symptoms might have gone away, and you might be presenting very well and just not be aware that you have a mental health problem. And he's like, I'm not taking the medication. I'm like, well, if you're not taking the medication, it'll show up in your blood, and then they'll know that you've been faking like you say you have, and you're fine. They'll take you out of the program. It's okay. A week later, my report's not completely completed yet. I get a call from his psychiatrist, who says that he is acting incredibly bizarrely and hasn't taken a shower for a week, is refusing his food tray, and is shooting with his finger at people as they walk by his cell. So I'm like, I'll go talk to him. So I go and I talk to him, and I talk to the nurses first. Nurses say he's been refusing his medication for last week. And I go talk to him, and he's laying face down on the floor in his cell. And I'm like, Mr. Doe, get up. If you want people to think you're crazy and you're being held past your parole date again, just stay on that floor. Otherwise, get up and talk to me. Guy stayed on the floor. He was also mumbling to himself, and I talked to the COs, and the COs said that he'd been acting very strangely for the last couple of days. So, when it comes to malingering evaluations, sometimes you just don't know. But obviously this was the case of someone whose MDO status was accurate, but was really good at faking good when he needed to. It was like the reverse of a malingering evaluation. Of course, he said there was nothing wrong with him. I gave him all the screenings. He gave his best effort. He denied all symptoms. It was one of the coolest type of evaluations that I've done. Unfortunately, the man had to deteriorate. We had to send him to DMH, and he'll probably be MDO'd again. But at least I now have a huge report saying he is really, really good at faking good. He will tell people he has no mental health problems. He will decompensate when not on medication. He will not be medication compliant, and he needs to have all these extra services. And sexual and violent predators. So let's move through this stuff really quickly so we can get to the good stuff with malingering. Sexually violent predator is an offender who has been convicted of a sexually violent offense against one or more victims who has been diagnosed with a mental disorder that makes the person a danger to the health and safety of others. In that, it is likely that he or she will engage in sexually violent crime. So it's kind of the same process. You have to have two independent evaluators evaluate the man. There are specific criteria. It's usually done while the inmate is still incarcerated, about 6 months prior to their parole date. And as we've talked about, they use the static 99, and both evaluators must be in agreement that the person poses a danger. And as you were saying, females are sent to Patton, males are sent to Atascadero or Coalinga, and they are re-examined annually. NGRI and guilty but mentally ill, we've talked a little bit about the case law here. The tests that are done are the RCRAS, which is the Rogers Criminal Responsibility and Assessment Scale, and the mental state at time of offense screening evaluation, not mental status evaluation, or exam rather. So the MSC is a semi-structured interview. I don't have either of these to pass around, I'm sorry. It's a technique that's really helped to screen out defendants for whom an insanity defense was not clearly applicable. And it's looks at historical information, offense information, and present mental status exam. This one is not necessarily well researched, so it's less used than the RCRAS, which is more often used, and it's pretty popular. It was designed in 1984 to qualify, and it qualifies the so-called ALI criteria. And it looks at reliability of report, organicity, psychopathology, cognitive controls, and behavioral controls.